The drooping tip deformity is a bothersome aesthetic feature and a functional impairment of the nose. Aesthetically, the distally displaced tip gives an aged and unpleasant look, and sometimes the tip also descends or plunges during smiling. Functionally, these conditions may affect the nasal patency due to an incompetence of the nasal internal valve that is altered by the tip malposition. Both static and dynamic factors may affect the tip appearance. The former linked to the malposition and incorrect shape of the nasal septum, upper and lower lateral cartilages, and the ligaments in between. The latter derive from the dynamic action of the depressor septi nasi and the levator labii superioris aliquae nasi muscles. When dynamic factors are involved, drooping of the nasal tip, elevation and shortening of the upper lip, and increased maxillary gingival show happen during smiling. The so-called plunging nasal tip. It seems logical to take into account static and dynamic factors along with auxiliary causes when planning to correct the drooping tip. Many studies have been examined this topic, but treatment remains controversial. In order to make nasal tip surgery successful, it is felt useful to identify the keystone anatomical characteristics of the tip itself. The method of tip evaluation position is also not uniform in different studies. Nasolabial angle, nostril axis, and columellar facial angle may be measured to assess nasal tip position. Although not entirely accurate, the nasolabial angle is often considered synonymous with nasal tip rotation. Patients with drooping tip have a nasolabial angle that is sharper than expected. The columellar facial angle seems most likely to yield consistent measurements of nasal tip rotation. More recently, 3 angles were measured on lateral view: tip angle, nasolabial angle, and columella inclination angle. Changes in aesthetic and smiling position were also compared. Patients undergoing primary rhinoplasty have been reported to exhibit, in the majority of cases, about 60%, a need for increased tip support, and to a fairly less degree the need for cartilage or other cartilage malposition. In a selected subgroup of cases, such as the patients affected by drooping tip, these percentages are expected to be obviously higher, and so is the need for significant correction of the tip itself. Still, this correction is somehow controversial, as we said. There are several tip supporting mechanisms in the nose. Due to the multifactorial causes of the drooping tip, the surgical strategy of intervention must take into account different maneuvers aimed to correct the static and dynamic alteration that may be present in each single case. The straightforward evaluation of the patient's anatomy will suggest the surgical steps to be applied. One key step is the re-establishment of the correct tip position in accordance to its length, projection, and shape obtained by framework modification. Thank you very much.